Andrew has a very large number of titles: Professor of Medicine, Director of the Usher Institute of Population Health Sciences and Informatics, and Vice Principal of Data Science at the University of Edinburgh. He's only fairly recently taken up those roles in August last year. Prior to this, he was Dean of Medicine at the University of Dundee. But as well as all of that, he's seconded as Chief Scientist at the Scottish Government Health Directorate, and he is also Director of the FAR Institute at Scotland, which is funded by the MRC and 9 other funders. And he's also convener of the UK Health Informatics Research Network. He leads a translational research team that focuses on epidemiological and molecular etiological basis of diabetes, but also has a major interest in how managed clinical networks can improve patient care across geographical boundaries. And sort of an English-Scottish type of a guy, Rod.
Thanks, Louisa. Unlike John, I am tempted to sing, actually. But I'll spare you that. So it's a great pleasure to be here. It is one of the world's greatest cities, Sydney, so thanks. I think it's my 5th visit in the last 2 or 3 years. And thanks for laying on this Scottish weather, which I'm enjoying greatly. So as John, just to echo John, this is a very important day to congratulate Louisa, Peter and Peter for having the vision to put this centre together. I want to try and convince you that medicine and healthcare is arguably the last major industry not to be transformed by the information age, and we are duty-bound to try and change that. I said that in Brussels recently. A German hand went up at the back and he says, "You're wrong, shipping." But we're not in very good company. But I would argue that there is an urgent need to change it, not only for the health of patients and populations, but this is about the sustainability of health systems internationally. You know, John, in your world, you spend 20% of your GDP on healthcare, and that is not sustainable. And that's because health systems are rife with waste, variation, and harm. So the question for me is, can we use data to improve the efficiency and effectiveness of health systems, primarily, whilst also supporting research at scale? So that's the script. As I said, it's my 5th visit here, and I think you've got a terrific opportunity in Australia. I see all the ingredients required to actually gear up at scale, but it will require systematic collaboration, investment, and alignment between health service providers, policymakers, and academics if you're going to seize this goal. So I'm going to sort of build on John's talk and just give basically a case study to say, can we do this at scale? So that's the script, and I'll canter through this so we finish. So briefly touch on global challenges, talking about what we're trying to do. Use Scotland as a case study, gearing an entire country for quality healthcare and research using data. Talk about the FAR Institute. Funders in the UK, firstly, have collaborated. So 10 funders have put £200 million into this space in the last 2 years, £200 million. And then make the case, and it's really the most important point, we've got to take the public with us on this. So with big data goes big responsibilities. So that's the script. So you'll be familiar with this stuff, chronic disease challenge. In Scotland, we've got great data. So this is our census data going back to 1911. And it's the demographic pressure. And I'm sure it's the same in Australia. Look how that pyramid has changed over the years. And that's what it's like in 2011. Some people suggest this is like the Manly ferry coming to hit us very hard. Because with that, we've seen a rise of chronic disease. And it's putting pressure on health systems. To illustrate this is a study published in The Lancet a couple of years ago. We took 2 million Scots, and we asked a very simple question. What does multi-morbidity look like in the population of Scotland? And if you look at the age of 75, few people are living with 0 or 1 disease. Most people have 2, 3, 4, 5, up to 15 chronic illnesses. And I subscribe to the view that this presents a fundamental challenge to the single disease focus that pervades medicine today. I do my diabetes clinic on a Friday. Sometimes I see patients who've seen the renal physician on the Monday, cardiologist the Tuesday, ophthalmologist on the Wednesday. So we need to stratify patient populations. So this is the first pressure. I'm sure it's the same here. The second one is, I was reading the paper today about your budget, and it's under a bit of pressure. It is in the UK. This is our Chancellor, George Osborne. We lost. Have you got your AAA credit rating here? You still got that? Well done. So these are Scottish finances. You know, we've got 39 billion whole. Our national debt is 1.3 trillion pounds. So this is a major challenge. So we've got to deliver, as John says, better quality care at reduced cost. And that's the game that we're in. So how are we responding to this challenge? Sometimes being in Europe, it feels like this. Believe me, carrying the world was much easier. The Grexit, as we call it, as they depart the euro. Coming from Scotland, I thought, who is a mythical Scottish character? So do you remember this guy? Remember him? Yes. So we're all doomed. But we think we can do a little better. So what we're trying to do is to use data to deliver better quality care at reduced costs, but also to accelerate that translational pathway. Because I would subscribe to the view at the back that this is very complex. And this translational pathway, typically, if I had a great discovery in the lab today, it would take 15 to 20 years to actually impact upon patient care. So what we're trying to do is get our information and data ecosystem aligned to accelerate that pathway. And I would argue that healthcare has come late to computer science. This is David Cooksey. He published a seminal report in 2007 which talked about translational gaps from bench to the clinic and from evidence into widespread adoption in the NHS. But what he also did was suggest that computer science across these domains can accelerate this pathway from basic research to adoption. And we've come late to that. So that's a key theme. How do we work with our computer scientists to deliver better quality healthcare? It's not about the computer scientists working for us, it's them working with us. So that's the theme. So I just want to touch upon each of those spans of the bridge and talk about, can we make it work with some examples? So patient care, because really that's why we're all here. And we're all paid by the public pound. So this is Scotland, just to remind you. If we'd voted yes in September, this is what the map of Scotland would have looked like. So we have a population of about 5 million people. We spend £12 billion a year, so that's what, 24 billion Australian dollars on healthcare. We've split it up. It's a bit like Australia. We split it up into tractable regions. We've got 38 hospitals, 1,000 general practices. But we've collaborated at scale on important things. And we've also benefit from having a unique patient identifier, so we can do deterministic matching rather than probabilistic matching. So this is our health service on a slide, because I know we've got some policymakers in the room. So we spend about $3,200 US dollars a year per capita on healthcare. We've got 16,500 beds, 12,000 doctors, about 56,000 nurses. So that's our health ecosystem across the scale. What does that translate into? It's activity, and what we're seeing is a rise in activity. So about 16 million GP contacts, which cascades into about 1.5 million inpatient or day cases and about 5 million outpatient attendances. So that's what we do every year, and it's increasing every year. So that's our health service. The challenge is, can we make that more efficient and effective? And what we try to do is use this number. It's not rocket science. This is my number. As you can see, it was a big year for me last year. There aren't 5 genders in Scotland, I should say. And a checksum to make sure it's valid. And what we're trying to do is link data along the journey of care of individual patients. Because if you've got a chronic disease, you often bounce between institutional structures, from primary care to the pharmacist, the physiotherapist, the consultant. And if your data don't follow you, you have fragmented care delivery. So what we're trying to do is join that up in a structured way. So examples of that, this is very clinically focused, but 3 quick examples. The emergency care summary. So 99.9% of the population are covered with this. So if I'm admitted to any hospital in Scotland, I, through a consented system, can give my consent for the attending physician or nurse to view my health record, which is extracted from general practice twice a day. We established it about 9 years ago. There are 3.5 million accesses per annum, and it changes the management in 20% of cases because people know what's happening. We know what drugs you're on. We know what allergies you have. So, and it's been very well received. PACS, John talked about PACS. Every radiology department has its own way of doing this. So again, nationwide approach. 38 hospitals, 20,000 browser stations, a national picture and archiving program, up to a petabyte of data, 24,000 registered users. So it means that wherever, again, I'm seen in Scotland, I can see my radiological trace going back right across the nation. 10% reduction in re-examination, because the doctor's pen is very expensive. They just say, oh, we'll have another one of those. So you don't need to do that. And we've now got 17 million studies for not only care, but for research, a longitudinal basis. So that's an example. This is my own area, diabetes, and this is about registry-based care, which I'm a big fan of for the last 12 years or so. Every person living with diabetes in Scotland is on a single secure clinical information system. Again, it goes into all 38 hospitals, all 1,000 general practices. This is it shown schematically here. Uses legacy data, so you don't need to rip and replace. It's using information you already have in your own health systems, pulls it together. I get lists of my patients in my clinic. I can see who they are. These are anonymous, of course. I can see their biochemistry over time. I can see what prescribing they're on, regardless of who's prescribed it. I can see what the podiatrist has done, the specialist nurse has done. I can see the retinal images, regardless of where that's been done. And the good news for this, for the last 8 years or so, if we look, this is nationwide data. We've been collecting these key process measures. So we think if you have good performance here, it translates into better clinical outcomes, and it hits about 95% of the population. And what we've published on several years ago is that we've seen a 40% reduction in amputation, about 40% reduction in sight-threatening blindness. These are our national data, about 120 less major amputations a year in people with diabetes. And it's my hope that I'll see a year when there are no causes of blindness due to diabetes, because I think it's a preventable disease. Recent data, the US data suggests if you've got type 1 diabetes, you lose about 18 years life expectancy. We're losing about 11 years in men, 12 years. This was in JAMA just a couple of months ago. 12 years in women. Still unacceptable, but year-on-year improvements. So Mark Walpott, our Chief Scientific Advisor to Westminster, he was very kind. He wrote about us in the Times a couple of years ago. If you live, I only gave him £10. If you live in Scotland and suffer from diabetes, you've been recently taking part in a medical revolution, he called it. But this isn't a revolution. This is what care should be. If I'm living with a chronic disease, surely I should not be able to fall through the cracks in the system, because that's the way we arrange our services. So, and it's these stories, because we talked about public trust and transparency, it's stories like this that actually allow one to address these thorny issues of data sharing, because it's focused on the patient and the health of the patient and the population. So that's the first bit. But with my chief scientist hat on, I'm saying we want to deliver world-class care, but can we sort this out as well? Harness life science, John's genomes, that's got a rhyme to it, through translation trials and innovation to actually improve the quality of the evidence base. And I think what we need to see internationally is a convergence of care with research. Often the research budget's out here and the care budget's here. But in this space, if we see a convergence around a common purpose, I think we see benefits. So that's what I'm going to try and convince you of now. So what we're doing, we published our revised strategy So we want to build, it's the same here, I think, build on your great basic science, create systematic collaboration with a tripartite mission, so that's care, education, and research, with a significant infrastructure investment, so you're not relying on project-level support. Thirdly is the data piece, use the data. Fourthly is the regulation and governance of health research. Fifthly, collaborative arrangements with biotech, pharma, and medical devices industry. Because the best way to pull people out of poor health is to give them a job. And it's about time that health services are seen as an asset in terms of economic growth rather than a liability. And what we're trying to do is position Scotland, 5 million people, as a single research site. So that you can come here and do research. So that's the script. So can we scale? So we've got leadership across, all these people work for different organisations. We've zoned Scotland into 4 places, and we meet every month to decide strategy. So it'd be like New South Wales R&D strategy meeting monthly. It's an academic health science network model. And what I do as chief scientist is give out about £10 million a year to these nodes to build unified clinical research facilities, safe havens for the data, research imaging, which we try to calibrate across the nation, project management, and tissue biorepositories. So just to show you how that pans out, this is our biorepository network. We've got strategic collections which are disease-specific or family-based, so we've got about 300,000 people consented for genomic studies which are within a single inventory. Synapse, so we've calibrated our technology across the country. Synapse is the nationwide imaging collaboration. Calibrain, we quite like that. We sent this poor Glaswegian around to be scanned in every scanner, and his head is still throbbing, I think, because of this unique bias that John referred to. Regulatory sign-off. So academics and industry love this. We have single ethics, single R&D approval for the country, and now we have single. Do you not have that here? So. And with single contracting. So if you come and do a phase 3 study, you get a single contracting. And these are R&D approval times. These are a little out of date. We're now down to 10 days R&D approval for the country. So that's the infrastructure. And this is just about, this is not rocket science. This is alignment and agreement to agree instead of having death by committee, which we're all good at. So a few case studies. Does this work? So just what about clinical trials? So this has been a bit of a success story. Because of this electronic data, we can screen against the database for eligibility for studies. So it's very efficient. But we've gone on to do that. But we've created a national research register called SHARE, and you can see this on the web. Because the Scots, I'm sure they're like the Australians, they really like participating in research. So it's a register of people aged over 16 in Scotland, interested in general helping medical research. We don't know what that research is going to be, but they consent to being screened, their data being screened. And currently, we piloted this, but currently it's about 90,000 people, and we're hoping to get up to 1 million people on this register. So we can screen prospective studies. And what that has resulted in, I don't know, it'll be the same in Australia. 10 years ago, 10 to 15 years ago, we used to do about 10% of the world's phase 3 studies in the UK. And then we hemorrhaged activity to China and Eastern Europe. However, we're seeing a lot more activity now. So these are important metrics, first UK patient, top global recruiter. And it's good because if you get industry engagement, other benefits earlier in the translational pathway emerge. And in terms of the money, in the last 3 years, it's about an £18 million per annum turnover for purely phase 3 studies. So that creates about 200 jobs. When I speak to ministers, I say that's the same as a small car plant minister, because they know, they look around car plants, and they know what a car plant is. But of course, this is distributed across the nation, so it's more difficult to see. But you get the idea. Here's an example using our imaging. This was in The Lancet about 6 weeks ago. Chest pain. we have a clinical pathway associated with chest pain. We got a new technology. It's called CT coronary angiography. Should we use that? So Dave Newby and colleagues thought this was important, because even if you present with chest pain and you're said to have non-cardiac, there's still a significant mortality out at 6 years. So it suggests the current pathway, which is ECG, bit of exercise testing, maybe a bit of traditional iodine-based coronary angiography isn't working. So what Dave said is, does this add value, this new technology, computed tomography, coronary angiography? So what he did was a study, again, across the centres, which are calibrated. We used 12 across Scotland, using our national infrastructure. And what he was able to do, so it's quite a big study, he recruited 4,000 out of 9,000 all eligible patients. It's a remarkable recruitment rate of about 47%, because we've got systematic approach. And what he showed, I won't go into it, but yes, it makes a big difference compared with standard care in terms of future events. It changes the diagnosis 1 in 4, changes the management 1 in 4. So it shows you how this network can answer important questions. They did a similar study in the States. It cost $40 million. I, as chief scientist, funded this, and it cost £800,000 because of the... No. I actually turned it down at first peer review. So secondly, can we use data to evaluate policy? I see Mary's here, and this is important. So we had a smoking ban. Do you have a smoking ban here? Yeah. So the question, the policymakers, did it work? So these were both published in the New England Journal, Jill Pell. So in terms of acute coronary syndrome, this is before the ban, and after the ban, admissions fell by 17%. 60% of reduction was in non-smokers. So it's good, evidence-based policy. This is hospital admissions, this panel here, for asthma in 5-year-old children, okay? So even in Scotland, 5-year-olds don't smoke, I have to say. So before the ban, and sort of increase in autoimmunity. After the ban, 18% decrease. So using data to look at policy. It's something else, diabetes related. We arbitrarily say, if you've got diabetes, we'll screen you annually. Is that right? Is that the right screening interval? So this is using our own data to stratify patient pathways. This is a complex slide. I won't dwell on it. But basically, we showed if people with type 2 diabetes had 2 previous examinations showing no visible retinopathy, we can safely offer them 2-year screening because their risk is so low. Now, as a doctor, my usual knee-jerk response would be, oh, well, we've got more patients, so we need more cameras, and we need more graders. But instead, we're stratifying the population. As you can see, you can safely screen 44% fewer people. And we've spun that back into the screening program. So using your own data to stratify your pathways. National programs, just to say that we are collaborating across the UK and, in these programs. International collaboration, because I think this is very important. I thought, let's choose another small oil-rich nation. So I chose Kuwait. But this is a package of scientific research, education skills, and informatics. And their health system's really fragmented. But actually, we were able to use the data they had, pull it into a single portal, and you'll see that the Kuwait network is very similar to the Scottish network. So this is, my view is that this model is transportable. And lastly, I won't dwell on this because John's covered it so well, genomics and precision medicine, but it's the same notion, phenotype cohorts, epi, but can we use it for genomics? And this is the slide in the year 2001 when, this is Bill Clinton, you'll recognize him, John. This is Francis Collins, Craig Ventnor of Celera Genomics. Tony Blair was also there, but I cut him out. So, you know, it was we can now do it for $1,000. John Mattick's got the alumni platform at the Garvan. We've just purchased one, and we'll do it for about £700, I'll let you know. So it's remarkable. But what one is able to do, and this is a few years old, we're going to look at population pharmacokinetics from routine data. So we took routine people with diabetes, routine prescriptions, routine therapeutic response in terms of A1C and looked at genome profiling. And that allows us to discover new biology to look at response and non-response to disease. So I think this will have an impact. And as you know, in England, we're sequencing 100,000 genomes over the next 5 years in rare disease, cancer, and infectious disease. And we're going to join the team effort across the UK. In Scotland, we're joining Genomics with Stratified Medicine Scotland. We've set up an innovation centre with industry working with academia and NHS to do this. So the idea is we use our data, whether it's the omics, the imaging, the e-health, and we do disease-specific exemplars. And we've gone one step further. This is the largest hospital in Europe. It's just been built. It's called Glasgow. It cost £1 billion. It's the only thing you can see from space in addition to the Great Wall, we think. This is the helipad here. You can see it. But within that, because this is about breathing the same air, within that hospital we've put an imaging suite, but we put an innovation space where the NHS, academia, and industry co-create around stratification. We think this is an important model. So I put, as John was speaking, I put a picture up of your hero. Here he is. Because you're doing a new initiative in precision medicine, and you're putting about $130 million into a million-person cohort. So this is happening internationally. So I applaud the work you're doing at the Garvan. But the key will be collaboration. And it's your point again, heterogeneity. Here's the slide which confirms that cancer is complex, complex, and complex. This was in Nature a few weeks ago. And if you look at 21 common cancers, and if you look at 4,700 individual tumors across 21 common cancers, the rate of commonality of genes is very, very infrequent. In only 13 genes was there more than a 1 in 20 commonality rate. So heterogeneity and complexity is the challenge for us. And because of that, many of us are contributing to the Global Alliance for Genomics and Health. I chair the eHealth subgroup. What we're looking at is an international coalition to say, if we're going to understand, because I know if I had bowel cancer, I would want to know the specific mechanism which was relevant to my tumor. And if we're going to solve this as a human race, we're going to have to collaborate at scale, as a result. Okay, so in the last, am I okay for time? So there's some big issues here, okay? So I'm just going to touch upon them. The first one is the data piece. This is going to be a lot of data, and John's really done all this stuff. So we need new approaches to data management. The technology is not really a problem, though. Other industries have sorted it, software as a service, platform as a service, instead of us all saying, I want my own server under my own desk. And that's what academics say. I need to be able to see where my data are. And those days have to go, actually, if we're going to do this. Because you just waste public money replicating a cottage industry. Because that is the future of medicine. Do you like that slide? I'll show it to you again. There we go. That's right. We'll move on. So the future, this is what John was saying, the future of healthcare, quality healthcare is not only about personal health data, GP, but it will be at many other data types. So that's the first one. The second big issue, I'd love to know how Australia's doing, is the maturity of health systems. So this is a blunt instrument. This is called the HIMSS. The Americans invented it. It's the digital maturity of health systems from zero, fragmented point solutions, up to where we all want to be, personalized medicine and prescriptive analytics. In my role as chair of UCL Partners North London, we did one of the first population-based assessments of digital maturity, and we're sat at 2.3. Germany's 1.7, Spain's 3.5, Europe's 2.9, America's a bit ahead. So our health systems are not very digitally mature. And the biggest problem we're faced is actually people's desktops and Windows version. And actually there is a challenge around the digital maturity of systems. So I think that's the second challenge. The third one is delivering at scale, and I'm delighted Peter's here because you remember this young man. He looks like a Conservative Party candidate, but he's not. Because we're trying to do this across the UK. So after a competition, Manchester, Scotland, Wales, and UCL were awarded. They're probably upwards of £100 million they put into this space, okay, from 10 funders. Because we want to do this so we can run studies at 65 million people. And to do that, it's about federated agreement. And we want to be really good at the international standard in the trustworthy use of data. Named after William Farr, eponymous, you'll recall that he was the father of medical statistics. He insisted the cause of death was put on death certificates, so that's why we called it the Farr Institute. And what we're trying to do is create an infrastructure, do great research, do great capacity, and do great public engagement. So very similar to your 5 themes, Louisa. So we've got a lot in common. So this is where we are. And you'll see in Scotland, if I take this as an example, look, we've got universities to work together with the health service provider. And it's a very strong message. If you go and knock on the door of the Ministry of Health and say, I'm a researcher at University of New South Wales, I've not discussed it with anyone else, can you give us some money? They're not going to give you much money. If you go as 5 or 6 universities with your local health districts and say, we want to do this, politicians like a fair wind behind them. So I would really, and this has been a tremendous collaboration. So these are, I won't dwell on these. We're doing leadership, research, public engagement, governance, and we're focusing on various research priorities. And so this is the Scottish Farr Institute, which is a research hotel. So we've put together academics from across these institutions with NHS providers, with industry, and now with government in this institute that we've built. There's no data there because it's about the people. It's not really about where the data are. So these people breathe the same air and they love it. Do you know what they like most about the building? Is you can see the free parking. But it's about getting the people together. And we've done the same in London. So this is the Euston Road, just outside Euston Station. There's Manchester buildings and there's Wales buildings. And one of the things we're doing, 2.5 million people in the UK have consented to cohorts. 2.2 are currently alive. So we're linking these people to the electronic health records that the Farr Institute has put together. And we've actually gone one step further in Scotland. So this might interest you. A lot of causes of poor health lie out with health. So the Economic and Social Research Council have created administrative data research centres, and we've co-located it within the Farr Institute. Again, it's a collaboration. So what that means we've got is national level data resources in health and education, our vital statistics, but also the ability to link on demand stuff like work and pensions data, to look at social determinants of health. Through the same data model. Big issue 4, and I'll speed up, is this computer science issue. We've got to bring computer science into medicine. And this is Dave, my mate, who led the School of Informatics. The reason I went to Edinburgh is shown in this slide. This is our ref. This is the power of universities, the top 10 most powerful universities in computer science. And Edinburgh, this is world-leading research. No, that's world-leading, and that's internationally excellent. We've got 1,000 informaticians looking at this stuff. And I think the key is can we get this alignment? Because this is where we sit. We've got agents, systems, people, and populations. We've got personal data, organizational data. We've brought alongside the genomicists, the health informatics guys, the social scientists, and the NHS. But the real key to success is to bring in these computer science modalities, machine learning, robotics, sensors, social computation, security, etc., to co-create and look at answers to these problems, new therapeutic interventions. So that building is full of computer scientists. You know them because they all wear sandals. So I haven't quite gone to that level of collaboration yet, but that is our view. We've got to get these disciplines aligned. And we've put huge investment into this across the estate. And just to show, this is Edinburgh alone. We've raised externally about £120 million for the Higgs Centre, because Peter Higgs won a Nobel Prize, so we built a Higgs Centre, a data lab, a CDT, which is a doctoral training program, and the Alan Turing Institute. So that's the scale of investment. But what we've seen, and the benefit of that is, this is a map of Edinburgh. What we've seen over the last 5 years is this emerge. It's a cluster. These are companies. So we're seeing people co-locate because of that expertise, and it's driving. So that's the economic growth side of the argument. So the biggest issue in the last 2 minutes is designing for transparency and trust. With big data goes big responsibilities. This is Edward Snowden. And this is the most important stuff. We've worked really hard at this. This is Professor of Law, Graham Laurie. It's about getting this issue of data controller, data processor, public trust sorted. We've worked at public engagement very visibly, or the publics, so they actively engage and guide how we use data and how we structure data. And what we've done is use that information to get policy. So with my chief scientist hat on, we got Scottish ministers to define policy, a data vision for Scotland. Do you have a data vision for New South Wales? I don't, but it's been really helpful to get, if this is purely an academic endeavor, it won't work, it won't stick. So we've got policy now, a data vision for Scotland, underpin that the data linkage strategy, underpin that a data linkage framework and how it works. And what we've said is we're going to have a federated network of safe havens, which are externally accredited, but work collaboratively to common security and data sharing principles. So we don't centralize this, but we have a federated network which communicates with each other. And part of that is to get single sign-off. So now we have a single National Privacy Advisory Committee, so you go to one place to get your approvals. I heard today that some poor researchers have been waiting 3.5 years for data here. They're best to go and get another job, actually. But why are we allowing that? We need to streamline that. So we've got guidelines of a 20-day turnaround time for that national committee. So to summarize, Louisa, thank you for inviting me to speak. I thought about medicine and information. What are the C's for success? Number one is commitment to public engagement in everything we do. Were the public invited today? I don't know. We should, hopefully there's some, well, we're all the public, I guess, but it's really important. This notion of convergence and care with innovation and research, all of this big data stuff, it has to focus on the patient. That's the number one priority, the clinical focus. This notion of collaboration between healthcare providers, government and academia with commercial engagement encouraged. This notion of computer science is key. At board level, we should have chief information officers. Maybe you do in Australia, I'm not sure. And this clarity about governance and data sharing. So I think today is a very important first step. And what I've seen in Australia over the last few years is the ability to actually lead in this space. And I wish you very well. So thank you for listening. So this is one of the world's great cities. This is St. Andrews. It was funny, I was supposed to be playing golf yesterday, you see, but I said, I can't, I'm going to Australia. But I was very pleased. And I know you've had bad weather, because yesterday morning I got an email from, this is where I play, that's St. Andrews. Because they emailed all members to say, this is when I was supposed to be playing, at 6:15 a.m. the wind is making it difficult to even stand on the 18th green. and the current forecast is for the wind to increase even further. So I know you think you've got bad weather. But yesterday I was glad I was in Sydney and not in Sydney. But I'm flagging that because we've got the Far Institute International Conference in August, and you're very welcome to come. And the sun will shine, it's guaranteed. And there's my email address, and if anyone wants any of these slides, they're more than welcome to use them. So thank you very much.